So meeting the gap, we're all challenged geographically with multiple sites, and we wondered how to best meet the patient needs and safety with limited resources. We all have staffing issues these days, don't we? Some providers currently do not have nursing support or a standardized process for this treatment. Nursing was identified to be able to drive process and standardization. Okay. Without a centralized group of nursing staff, providers have had to manage these patients without nursing support or without a consistent process, or sometimes they're asking our nursing staff to help them with this by perhaps doing an assessment or a screening without the nursing staff really having the training or a process in place for them. The goal is really to have a core group of nursing staff support additional clinics. And with our pilot, we will gain a better understanding of the nursing time and FTE needed. I'm sorry, I flipped the slide too soon. So that happened, I think, last time I spoke. So one last thing from the previous slide, I guess I could go back. Our goal is really to do home inductions rather than on-site inductions. The on-site induction can take up to 4 hours and is resource intensive, and patients really, in fact, can be in their home and do the home induction, and probably it's not a comfortable situation, but they're in a comfortable environment for them, hopefully. Okay. So now we're going to talk about our virtual RN visit process. So there's multiple points of entry, and so the nurses need to be able to adapt to where the patient is at. The initial call can come into our nursing staff from the patient themselves asking for help, or from a provider. The provider may be from the emergency department. Our emergency department is currently starting patients on Suboxone with the intention that primary care will manage that afterwards. So, or it could be OB. We've had requests from OB to also participate in this. Or it could be the primary care provider or an outside provider. The first phone call is we say initial phone call, is really a screening phone call with the patient. They do the Vermont questionnaire. That's where they're collecting a history of substance use and social history, including if they've had a similar treatment in the past. What they're doing here with this initial screening phone call is really to gather enough information for the provider to determine if this patient is a good candidate for Suboxone therapy. The rationale really for doing this screening phone call is that the assessment and education visit, it had been taking up to about 60 minutes, and that's a long time for the patient and for a nurse to spend in a single visit. And so they pass the information on, and we want to make sure that the patient is appropriate. Then we move on to the virtual, hopefully video is preferred, but we will do it by phone as well. In that visit, they're doing an assessment. They're looking at relevant past medical history, a more thorough substance use and social history, a focused medical history, and psychiatric history. They do assign multiple questionnaires, including the PEG, which is the chronic pain scale, and then the Epworth sleepiness scale, the mood disorder, PHQ-9, GAD-7, and the DAS-10. The DAS-10 is the drug abuse screen. They also provide education to the process and expectations for the patient. Some of the expectations for the patient is really they need to receive all their health care from the clinic, from our clinic. It's important for them to be honest and truthful with their questions. We're not here to judge them, but we just need them to be honest. We talk about what buprenorphine or I'll call it Suboxone, naloxone, and what will help manage withdrawals, that it will help manage withdrawal and cravings. The form it comes in, it can come in a film, that's what a lot of our providers are using, or a tablet. What induction is, what is it when they're considered stabilized, so when they no longer have cravings or symptoms of withdrawal. We let them know that typically they'll have to come in every 2 to 3 weeks, and then it'll go to 4 weeks. They get their next prescription for Suboxone when they come in. That's a face-to-face visit. This is all in this education and assessment phone call. And usually about after 6 to 12 months, they can come in to see the provider every 2 to 3 months. They don't need to be in withdrawal when they come for their initial visit with the provider, a face-to-face visit, because the provider's going to talk to them about the home induction and give them the instructions, talk through how to titrate up their dose. We do tell them that they do, for the home induction, need to allow 2 to 4 hours to go through the process. We also talk about, along with expectations to be in our program, also we talk about termination from the program. So we want to be clear, we do have an agreement that they are required to sign when they come in for their first face-to-face. Then the RN will pen orders for labs, urine drug screen, HIV, hepatitis C, pregnancy test if applicable, and then they help set up the first provider visit, the first face-to-face visit. And that's where they'll get further instructions from the provider about how to titrate, which I already mentioned. The patient then does a home induction, and then 1 to 2 days later after they do their home induction, then there's another follow-up visit with the RN, and there they're talking about their cravings. They talk to them about cravings. Did they relapse? Did they use any opioids or other drugs? They perform the SOWS, which is the subjective opioid withdrawal scale. And if that is an elevated score, they will arrange for a visit with the provider sooner because they likely need to titrate up on their dose of Suboxone. Okay, lessons learned. Do I use this? This. I'm not tech savvy, you guys. That one? Okay. All right. So the lessons learned. Various streams of entry into the practice. The best thought out workflow that you have, it's not going to cover all the possibilities. Calls, like I said before, can come in from the patient, the ED. Our hospital is going to start doing hospital inductions, hopefully sometime here in the very near future, and with the assumption that primary care will manage that treatment.